Hello, everyone, and welcome. I'm Shelley Gunther, sonographer and clinical marketing manager here at Clarius. We're so pleased you joined us for our very first urology webinar titled POCUS in Urology, 5 Ways to Streamline Patient Care. Urologist, educator, and fellow Canadian Dr. Zorn will join us in a moment in what promises to be a highly educational session. You're among just over 900 urologists, nephrologists, hospitalists, and primary care clinicians who registered for today's popular session. You're about to see how POCUS of the lower urinary tract can supplement your physical exam, optimize clinical workflows, reduce wait times, and improve outpatient management. Following the presentation, I'll be doing some live POCUS scanning, so please stay tuned. I'll give a quick demonstration on how to scan the kidneys and the bladder using the Clarius C3 scanner, and I'll also do a quick demo of our new Clarius Bladder AI. At any time during the webinar, please use the Q&A box to ask your questions. Dr. Zorn will address them in the live Q&A session following the presentation. Now let me introduce you to our host. Dr. Oran Frankel is an emergency physician trained in California. He's a passionate POCUS educator, and Dr. Frankel has been using point-of-care ultrasound his entire career. He practices emergency medicine in a busy academic teaching hospital right here in Vancouver. And we're fortunate to have him as the chairman of our medical advisory board. Hello, Dr. Frankel.
Hi, Shelley. Thanks for having me, and glad to launch off this urology series. To set the stage for our discussion today, we're going to go pretty broad, given it's our first urology webinar. And the first study I wanted to review when we did our brief literature review was largely just an assessment of the status of point-of-care ultrasound training and exposure and utilization with perceptions and use among urologists across a wide range of practice. And while this was a survey-based study, about half of the participants who did reply were in an academic practice. 2/3 of them have already been at work for a decade. And what the survey discovered is that POCUS is becoming more widely used in many practices across the board, from both office-based to hospital, but most urologists haven't really had any formal training, and they do desire it. And so here's an opportunity with our webinar. We're hoping to provide some additional insight into use cases and where it can be integrated. And, the other paper we wanted to review was another kind of basic review article on how really taking ultrasound to the point of care by the urologists themselves is a quick and cost-effective and time-saving modality that you'll see both for the physician and the patient. And it can be used either for obtaining the first or the final diagnosis. And then with results at hand, patients can be selected for appropriate management or further assessment. But we'll get really into the details on how to better streamline care with our guests, who we're going to invite on in just a moment. But before we do, we have practitioners from across the world at different stages of your practice. We wanted to put up a quick poll to see where are you at with using ultrasound in your practice, and how often do you use it to assess your patients. So we'll pop this poll up here quickly. And is this something that's new to you, where you've never done it, or you're just learning, or are you already a frequent user, maybe integrating ultrasound weekly or even daily into your practice? And this is a quick question. We'll close it out. And we'll see what our results are here. Oh, great. So we're really across the board. Some of you, about 1/3, already using it daily, which is great. And then many have never used it or just learning. So we have a total wide spectrum, which is what we love to see on these webinars, because it means our guest has something to teach to everyone. And I'm very happy to introduce our speaker today, Dr. Kevin Zorn, who joins us from Montreal, Canada, where he's the director of BPH Canada, a personalized private prostate solution center founded in 2023 to offer all approved BPH therapies to Canadian men. Throughout his career, Dr. Zorn has been at the forefront of adopting and introducing cutting-edge technologies in urology, including POCUS and disposable cystoscopes, to improve patient care and safety. Dr. Zorn is a world-renowned surgeon scientist in the field of urology who continues to make significant contributions to urological education, research, and clinical BPH services. As a globally recognized surgeon and educator, he's contributed to over 345 peer-reviewed publications and has played a pivotal role in advancing urological education and clinical practice worldwide. Dr. Zorn, we're going to hand it over to you.
Well, thank you so much. I appreciate the introduction. Thank you, everyone, for taking some time on your Wednesday to spend with us and to share a bit of the journey, the story that I've had, and how I think really transformatively accelerated part of my practice to allow me to, make my iPhone even better and really become a better teacher, better clinician, make quicker decisions, and especially, times of essence, to make everything just more fluent. So titled Wireless Handheld Ultrasound in Urology, which I think is quite fitting for urologists with regards to what we were taught. And you look back at sort of the Campbell's Urology, the art of uroscopy, just looking with a flexible lens into or even a rigid lens back in the time, to what that was the founding portions of urology, to now the practice that we run now with PSMA and molecular biology and so forth. Our current practice is very much unrecognizable to what was first started off urology. So I think urology, ultrasound in urology is something that's already we're very familiar with, reading our own images, ordering special tests, certainly from the kidneys down to the phallus. All that soft tissue can be evaluated. And to me, this ultrasound is just really an extension of the physical exam. It's safe. There's no radiation. It's real time, and we can interpret that and demonstrate and show our patients, be it us or even in the emergency room. I think that just adds to the experience and the trust and for really the quick interpretation to allow faster delivery of care. Certainly, when I first got interested in this and reached out to the AUA, they had these hands-on courses, because exactly that, we don't really have formation during our training. We learned how to, fill out a prescription pad and send it off, and we send our patient to get their imaging, which adds time, complexity, and certainly now post-COVID, a certain level of difficulty, especially for our elderly patients. So there's these hands-on courses. I said, look, let me get involved. Pat Fulgham said, come on down, we'll spend some time, and there's a formal process, and these sell out. I mean, it still continue to sell out because there's a great demand, and to which I think, it just allows us to become better clinicians. You can add to your more comprehensive examination. And certainly in certain parts of the world, this is something that's a billable event, and that you can, add to revenue aspects for the practice. Urology, soft tissue. I mean, we're not doing in the brain, we're down below from the kidneys and the retroperitoneum. We got the abdominal, liver, kidney. You can see if there's hydronephrosis. We'll cover some of these things in the following slides. In the pelvis, we have the bladder, the prostate for males, the scrotal exam, soft tissue, and certainly penile is another area that for erectile dysfunction, Peyronie's, which again, great value in measuring, assessing, counseling, seeing differences for our patients. And I think, just the ultrasound is going to continue to grow, be it from HIFU, ultrasound therapeutics, to fusion biopsies, which again, transferring from transrectal to transperineal, and perhaps even using AI targeting for the future, but at least now MRI guided. And I think with SpaceOAR for protection for rectal wall injury. And then we'll see down the road, I think, some of these contrast enhanced ultrasounds or micro ultrasounds, which are just phenomenal in terms of 29 megahertz, which are even competing with some of the accuracy of multiparametric MRI. So growing up as a resident at McGill, that's an ultrasound. It's this, 100,000 plus device that requires to be plugged in. It weighs a ton. You got to wheel it around, or the patient has to come to that room to be examined. Again, they're large, they're expensive, they're wired. There's paper or not. So these are all aspects. There's so many buttons, part of the knobology of learning these, which again, it's very great technology, but it's not something that's very practical for especially urologists. If you're a resident, you're running around in the emergency room, you're in the ICU, you got called to the floor, it's 3 a.m, you get it. So you need something that's gonna be wireless, it's gonna be portable. And if we can, what screen does everyone have? Well, you got the iPhone or your mobile provider, for Androids. And that's what's cool, is that this now is a cool device that from month to month you get, new updates that you can make like a Tesla. You've got the best model, but you want something that's small, light, portable. That's going to be this sort of point of care. So the delivery is wherever you want it to be. It's in the woods, your backyard, the emergency room, in the car. I mean, you can take this anywhere. This now competes to something smaller than my iPhone. And it turns my iPhone into a teaching tool. So that's it. So, there are a few other companies that have tried out the GE, I've tried the Butterfly, and at least what I loved about Clarius, aside from being Canadian made, is that they have different profiles. So you can have the C3, which is the one we'll show most. And I think from urology, if there's one that is the tool for all, it's the C3. It's got maximal depth of 40 centimeters, the frequencies between 2 and 6 megahertz. There's also the one and only endocavity. So for gynecology, urogyne, or urology looking to do diagnostic or therapeutic, we'll dive into that. But it's a very great tool and has specialized sheaths on the side that allow for needle track or biopsies. So that's something else to consider. And then you have the L15, the linear, which is a great tool if you're using, if you're big into the penile Doppler, great accuracy, better frequencies for that for linear. But again, all three can be purchased, and I think all three lend itself for urological practice. So the one and all, like kind of my stethoscope, which somewhere on my wall here I have, which I barely use and doesn't really add much to my practice. This has become the stethoscope to allow me to assess the kidneys for hydronephrosis or renal cyst, or if there's a mass to follow, or post RFA to see if there's a scar. And I can do that myself. And again, it's just something so simple to check the bladder, PVR. So certain patients, if you need to check the bladder scan, and the Canadian system, our bladder scans are like, $10,000 or $12,000 by one company, whereas this handheld device of $6,000 or $7,000 can do that and so much more. So cost economically, it's great. And they now have this AI, which we'll demonstrate later, where you literally just need to press one button, it scans and does it for you and reports that. So you don't need a lot of skill set to do that. So I'll go through some of my BPH practice where, picking up bladder diverticulum, bladder stones. With LUTS, you can pick up bladder tumors. Is it vascularized? Well, guess what? I can throw on Doppler. There's so many cool technologies built into this device and the software. It's quite impressive. The linear, again, for penile Doppler, so men with ED, Peyronie's, plaques, if you're looking to do injections with Xiaflex or calcium channel blockers or what have you, great tool. For scrotum, if you're, see someone in the office with an acute scrotum, you want to know, is it a hydrocele, a hernia, what have you, very easy to do. And picking up any kind of testicular lesions. And then finally, the EC7, which, is a great tool for your measuring your trusses, prostate volume, especially in certain obese patients, where you may not get that contour through the transabdominal approach. Picking up seminal vesicles if someone has infertility issues. Again, could be used endovaginally as well for cyst prolapse or what have you for urogynecology. So we'll dive into that and some of the really cool options of using this for biopsies and for those looking to do MISTs, such as REZUM or Optilume or iTIN, where you want to get a block. You can do this very nicely and keep your eyes on focus, and we'll cover that with a video. So I just think that, to me, this is just an extension of the physical exam. I went as a tour with the EAU CUA exchange program, and here I am visiting different European countries, and this is part of their practice. Everyone had this in Germany. Everyone had this in Leuven. So it was just coming back to see, wow, this is something that just standard of care across Europe. So to me, it takes our five senses and this for urologists to a new level because it's not a great tool. So it's something that can be transportable, fits in your bag and has a very good battery life to last you through the day, at least for my practice. In the emerge, in the clinic, in cystoscopy, and is my catheter in the right spot? Operative theater, we want to see if the double J's up. You can do that in a pregnant patient. Teaching, education. So there's built into the software that you can have a conference call and show the images or capture a video, capture images, and either, to the cloud, print it up. We'll give it as a medical file to the EMR, or share it with the residents, or share it with the patient. Getting that second opinion, we see something that's abnormal. My other colleague signs up on Clarius app and he sees exactly what I'm seeing real time. And again, some of those advanced softwares, which again, we didn't speak much of, there's B-Wave, the gray scale, but we can throw on Doppler. We can check elastography. We can look at power Doppler for vascular flow. So again, great tools, very helpful and built in. So it's not like you need to buy this and there's up programs. This comes with the software. So since 2016, I've done quite a few. I've got a few scanners. And again, this is something that just a testament of the facility. And it doesn't take much. It adds maybe 2 to 3 minutes more per my visit. But what my patients look at me, they're like, wow, that's on your phone. There's just such an excitement that you can see inside me and that's your phone. So again, it just builds that trust. And, to those starting up in their young practices, is that important to you that your patients, see and believe and kind of feel that you're a leader in increasing technology and delivering better care. So again, this is what the printout, you can go on their cloud. It's built into the your purchase with the device, that you have cloud access that you can click. And to those on the line who are urologists, they'll laugh when I say this, but you're doing your prostate check and the patient looks over, hey doc, is it bigger? And you're kind of thinking in your mind, I don't remember who you are and I don't remember what that felt like last, but quickly I can show get that printout. But last year you're 41, this year you're 47 grams. We know BPH can grow 2 to 3% per year from the Olmsted, from some of the longitudinal studies. So yeah, you can look back and say, yeah, you were this size, now you're this size. We do it for our kids, right? You stand behind the wall and put a little pencil and look, you're growing. But it's an organ which patients don't know. And unfortunately, these grow. And I think sometimes as urologists, we fail identifying those who are going to progress toward retention and only get to them when they have deteriorated bladders or retention. So again, nice tool, longitudinal assessments, and then we can answer the patient when they look behind and say, hey, did it grow? Give me a second, click, and there you go. You can see the differences in change. And that also correlates nicely with PSA density, which again, as urologists, we encounter a lot of those elevated PSAs, but for a guy with a 300-gram prostate, that may be a part of why it's a PSA of 5 or so. Again, let's go through the systems top to bottom. So we look at the kidneys, beautiful way we can just check cortical wall thickness. We can see if there's any cysts or mass. If there is, questions of vascularity, if there's trauma, you can pick up vascular flow or ureteric jets in the bladder if we were concerned of obstruction. And certainly any kind of thickening of the walls, be it the ureter or the collecting system. And just as what it looks like. So you simply apply this to the abdomen with some gel or any kind of liquid interface. I find sometimes the COVID hand soap alcohol just as good and helps clean everything up and doesn't get too gooey. And simply just, applying that to the abdomen, and we'll see here just, rotating and fanning. And these are some of the skill sets that can be picked up and learned. And I know that Clarice also has a good training program and online modules. So we'll just jump ahead here. So, the normal findings of a kidney depends on the age, the sex, if there's any previous treatments, what have you, but between 8 and 13 centimeters in length. We want to see that nice cortical wall thickness, or kind of like the steak of the kidney. That's the filtering nephron power. And you want to assess the cortical, the pyramids to assess to see if there's any hydronephrosis. So you can measure that length and you can nicely see with, I think, very nice accuracy, the hypoechoic nature of the contour of the cortex. And then that central fat, you'll see more white, much more hyperechoic. Or if you find an AML with angiomyolipoma, the fat content, similarly, you'll see that whitest tissue. And you can use that in the two senses, the sagittal and longitudinal views. And then sometimes you'll pick up some mild hydro, someone who just recently passed a stone, or you just removed the double J, or you de-obstructed and you want to see how things are going. Well, there you go. You can pick up some, from some mild to moderate. So, just simply just a little video to get a sense of what that looks like. And it's real time. There's no lag. It's impressive. And, you just show that to the patient, capture video. It's up to 30-second little segments, and even pictures sequentially, and really no limit. And the severe cases where you may see some chronic, and this is a patient with like a UPJ obstruction and narrowing of the pelvis, draining the kidney, and you can see some thinning of the cortex because of the chronic nature of the obstruction. And that's just some sagittal views here again. So just to show, what that would look like. And, for those who are urologists are like, yeah, I picked that up back in pediatric days with reflux disease, but yes, I think that's pretty obvious to pick up, and it's quite nice that the accuracy that you can pick that up. This is a case that I had seen for a left renal mass, and so just some images of the liver you can see in the longitudinal view in the mid, and then finally on the far right you can pick up this heterogeneous mass, solid in nature, and on Doppler did have blood flow. So again, for sure I'm going to send the patient off for a CT, but I've already engaged in the discussion. This is most likely what we're going to see. It's a vascular type of mass, get the ball rolling. So, that expedites things, and I think just allows for a lot of less anxiety. I think, unfortunately, patients are left sometimes in bewildered modes, and not knowing is sometimes worse than, our anxiety post-COVID brains take us to dangerous, dark places. So as a physician, if I can cut that out and help patients have a better experience, get treatments earlier, why not? So again, here's the next, jumping to the scrotum, looking at a scrotal mass evaluation. And, someone comes in with a scrotal mass and you examine them, and you can do a transillumination. You can feel it's circular. Is this bowel? Is this hydrocele? Is it septated? So normally would write the script, they go, maybe a month or two later, they come back, and who are you again? Oh yeah, okay. So there's that unpleasantry and colossal waste of time for both the patient and the physician. So right there, you can look and examine, pick up, hey, this is only above the testicle, it's a spermatocele, it's circumferential around the testicle, it's a hydrocele. Is it septated? Can we drain it? We can measure it. Or is it a hernia? And I'm going to send them off to another physician who specializes in that. Here's a case of an acute scrotum, someone who was punched and had a testicular fracture, which we saw as well, and had a large hematocele. So again, something else that can be nicely added to the evaluation and save time as we proceed to the OR. Next up, so the testis mass, so someone with an intratesticular mass, where you're worried it's a torsion, or you worried there's some kind of a cancer. So again, you're in the clinic, you can pick up this as an intratesticular mass. So rather than sending the young gentleman off to go get his ultrasound, then come back, and then engage in discussion, look, let's go get the markers, set him off for a CT. If you want to send an ultrasound too, but at least you've engaged in the discussion and the treatment and save time for this young gentleman.
Some of these applications seem really useful to bring in if you're on a call to emergency, instead of waiting for the radiology to perform scan, if the emergent decisions need to be made, to bring it in with you. Do you ever use it in that application?
Yes, I mean, again, some emergency people, and maybe you're in the same situation, but none of my emergency people have ever seen that. So they come to me like I've just been beamed down from Star Trek, and they're like, what is this? Where is this? And so they have some of their crash trauma ones. They're looking for blood under the liver for acute abdomen, but to get to that granular level, again, I just think that's a lack of knowledge, lack of access of resources. And again, so I think I'd like to see that. My dream is that, every urologist should learn how to get one of these and learn how to use it. It's, if you have a stethoscope, which is probably like mine, sitting on a wall, maybe listening for bowel sounds, it's not a very, and the time you leave it somewhere and you have to, where did I put it? And you forget it half the time. So this to me is just a great tool. And yes, it has helped in some of those discussions with Emerge to counsel and move things along. So I'm not saying I want to take over the job of the radiologist, but certainly I'm a physician. I have clinical judgment. I suspect certain things, and I can guide and feel more confident in that direction and move things along. And I think the patients appreciate it. Next up, we'll just talk about some of the penile access. So I think for Doppler, when you're working up someone with what you believe is vasculogenic erectile dysfunction, or in this case, a patient with some Peyronie's with a plaque, you can assess. Normally we kind of people write their notes with a plaque and they kind of grade it or its size. But here we can measure its thickness. Is there some underlying spongiofibrosis? And we can look at that arterial flow on Doppler. So that's what that would look like. You simply bring over the pattern over, and you can pick up whether or not there's significant blood flow. You can do the power Doppler and measure resistive index as well. So for those who are interested in some of the erectile dysfunction applications, they are all, again, possible with Clarius. Moving to my neck of the woods, what I use this almost on every patient, assessing bladder and prostate. Really, I think that there's a huge evaluation, which sometimes is missing in the details. So my colleagues in the past would just write, on a cysto normal. Well, what about the bladder wall? We know with BPH, there's thickening of the bladder, there's hypertrophy as compensation. We'll pick up that, and I think that's some of the earlier signs that we have obstruction is compensatory bladder wall hypertrophy. We can pick up other types of BPH specific disease such as bladder stones, whether or not there's a middle lobe, intraprostatic protrusion, diverticulum. And again, it just sort of helps us not just the diagnosis, but the treatment. As for those who are on the broadcast, if there's treatments if you're a 95-gram or a 25-gram prostate, there's different treatments that are emerging or currently available that are based on volume of the prostate and the presence or absence of a middle lobe. And finally, as I said, it really allows us to give us some interval changes. So we all see the PSAs, but is there anyone ever kind of ask a 40-year-old, a 45, a 50-year-old, what's your prostate size? Are you a grower or are you just a slow evolver? And there's going to be guys, every man on this phone here, at some point when you're 18, your prostate's maybe 20 grams, but some patients' prostates are 200, 300 grams. They weren't born like that, but we missed the boat on catching them as they're flying off the scale and perhaps offering treatments or getting them earlier in their disease process to avoid the hydronephrosis, the renal failure, the infection, and the we call it benign prostatic hyperplasia, but BPH is not benign. There's a lot of, costly and potentially dangerous things that can happen out of that. So again, this is simply the patient's on the table, they've done their Uroflow, they come on in and simply will lay this on the belly and I'll assess their PVR. And then I'll immediately go and look and zoom into the bottom of the bladder where you'll see yes or no, there's a middle lobe. And from there, assess the ecogenocies, as there's lots of calcium stones at the capsule. Are there cysts within the prostate? See if there's any hypoechoic areas in the peripheral zone. I'll measure the X times Y times Z. And really, you can see I'm two-handed. I don't need knobs. I'm simply just, in flow of what I'm normally doing. You don't need much different position or extra equipment. I'll bring up and be able to do pictograms. This is the left or the right side. I'll measure the bladder wall thickness. And from that point, move my way down to the prostate and do the X times Y times Z, which is already built in. So I don't need to sit there and use a calculator at the end. This is naturally done in the app. And to which at the very end, it'll help generate a report that you can either import digitally to the EMR or print it out for your records or print it out and give one to the patient. So now they've take this home and they say, wow, what a great doctor this guy is, or she is, that she helped me identify where I'm at and do this annually to see what their growth is. So get them involved, get them to be taught what's happening. And really, you don't need a big skill set to do this. And I've done this on large patients and various size patients. And again, there's not much in the way except for the pubic bone. And that may be the only thing where you may need to deflect down to see that apex. But really, the big key thing is that the bladder neck, is there a middle lobe? So I'll go ahead and jump ahead here. Again, hematuria workup for a gentleman who also had LUTS. And, we can pick up the ureteric jets. And you can see on the far left, those images of that sessile bladder tumor. It's a tumor, I wouldn't say it's too sessile, but it's a bladder tumor. So kind of knowing before cysto, I've got a tumor on the patient's right side, and it looks like it's going to be far away from the ureteric jet. So, already in my mind processing what I'm going to find out, the things I'm going to want to look for in more detail, if there's any associated CIS or secondary tumors. So again, that's a nice little tool that simply adds on another 2 minutes to the exam, giving you more information, which as surgeons or as clinicians, the more information, the better. And I think part of our EMR stress and overload and burnout is we're scavengers. We spend time trying to hunt down a creatinine. Oh, I got to click on this system. And oh, what's the CT? And oh, I got to call this person. So the more information's on our desk at one time, the faster decisions, the more time economic aspects we are. And let's be honest, time's the essence. You can buy everything else in the world. You can't buy more time. So if you can save a couple minutes per patient and make that experience better, why not? Again, just part of the BPH workup here and, measuring the volume. And this is pre-AI bladder scan. We'll be showing you some of the newer stuff, but that was one way we can do PVR and then measuring the volume. This was a referral to me for a large 60-gram prostate by rectal, measuring 130. So obviously the treatments will be very different in offering BPH surgery based on that volume and the fact that it protrudes significantly into the bladder. So if it's your first green light case and you have that component of a middle lobe pushing in the bladder, you may not feel as comfortable as doing some other techniques. So again, some food for thought of planning and deciding and decision-making with the patient for the prostate. So again, this was like a 55-year-old gentleman who presented with male LUTS, a significant IPSS score, and his Qmax was only 6. That's a slow flow, anything under 15 considered slow. This max speed, that's how it's measured for urine for the non-urologist on the call. And he avoided 230 cc's, but his PVR after urinating left is over 500 milliliters. So he's only emptying about less than 30% of his volume. So again, we use the Claris C3. Here's some of the quality images you could see. Lean, thin gentleman, and you can see the middle lobe. You can see that it was a 65-gram prostate, and it had quite a thickened bladder wall with small little cellulae, not a full diverticula. And then from that point, we took him for BPH outlet surgery and an aquablation. Here he is 1 month after. So again, just to kind of show what we did in terms of surgery and helping explain to our patients. So you can see here, the bladder emptying is much better. His on the second image, you can see almost like a defect at the bladder neck, the absence of that middle lobe now, and a central hole in the prostate, almost like a donut. So we were able to get his prostate down to 23 grams, which is a 65% reduction, just helping the patient understand what we just did to him. And then, this ultrasound could help us be not just, radiologists to our patients in some degree, but can it help us deliver the anesthesia? And the answer is yes. So we're able to, and those on the call who do any REZUM or BPH missed procedures where you want to do a block of the prostate, well, you can do that with this device. The EC7, the endocavity, it's the handheld, and we'll use, the sheath that snaps on. There's one that's dedicated to that. And as you can see, there's on the right, my hand holding the device, my hand pushing the syringe, and right before me, the image. So unlike, you're looking over here, where's the button? You're constantly like a pilot, switching your head gear and reorienting. My eyes are at the surgical site and the camera, everything there in front of me. So I find a little bit more comfortable and certainly more ergonomic. So here's the Civco and the model number. I'm sure we can provide that for those interested after, but that's the model that snaps on a disposable plastic part with all the other components for the block, the sheath for biopsies, what have you. When we do the block, this is something that was one of our papers we published on the periprostatic block, different sites of access, the classic seminal vesicle, so beneath the seminal vesicle, but sometimes you can puncture through the seminal vesicle and treat between the seminal vesicle and the bladder, which is the entry point for the neurovascular bundles as well, and vasculature to the prostate in the transition zone. So I find that's a deeper block for those who are getting a REZUM. And then certainly the apex, also those doing TURPs will know there's also blood flow coming from that apex. So the nerves follow the arteries. So doing that. So you can see here, in the position, I'm measuring the X times Y times Z. There's even a biopsy line that helps guide your needle placement. You can just, with a finger, just tap, tap. You're not having to spend time on a button. At the very end, you can use a grill at the bottom of the sheet that I helped work with Clarius to build. Just tapping, is the echogenicity normal? Is there a middle lobe? Yes. And so you don't need to sit there and type up your report. It's already automated. You just need to tap buttons, and you can even use Siri Dictate or your other, Android option to just record over your findings and your details. So it not only helps you be a better physician, but also for your clerical work makes it easier. So that's it. So that was our EC block study. We just did a small series. And we looked at visual analog scale. Was it as good for pain control? And those are measures on a scale from 1 to 10. And during the treatment, you could see 5. But hey, how did that do compared to the actual REZUM study? The Penthrox with Dr. Elterman, he had done an inhaled agent, and our Clarius pilot seemed to be as good, and it's certainly cost economic, not buying additional systemic therapies for the treatment. For those on the call here today who do TURP or green light, sometimes you're training residents and, hey, it looks like a nice channel. Did I get to the capsule? So you can simply place on the probe transrectally or transabdominally and have a look to see how you're doing relative to the surgical capsule and see the defect size that you've created. Again, something else that may help with residents or your own learning curve through these treatments. And also for the post-op, if there's some residual obstruction or so forth, you can pick up clots. Is there residual tissue? and also to see the defect that you've created in the center of the prostate. Here's a little study that looked at, was kind of brought to me, is the C3 as accurate as a transrectal? And we compared the two and also looked at the actual prostate weight for those about 100 men who had radical prostatectomy. We looked at specimen weight, we looked at the transrectal and the transabdominal. And as you can see that for those prostates, very congruent accuracy across the board with a slight variation between the two. But and then the other thing, I guess, as urologists, we pick up a lot of elevated PSA consults, and with it, patients are concerned. They've done their Dr. Google. They think they have prostate cancer. So again, something that helps us identify early on, maybe before we send them for an MRI, which is really I think the standard of care now, outside of extremely high PSAs or evident prostate cancers. But you can pick up with the clarity of this imaging, you can pick up these hypoechoic lesions, which in this case matched up nicely with the MRI, and he had cancer in that hypoechoic area. And just for fun, we threw on the Doppler and saw, is this a vascularized type tumor? And I foresee down the road, a micro ultrasound. I know that ExactView and a few others have, again, a tower setting, and they've done some great data to show its accuracy in prostate cancer detection as good as MRIs with some of the work with Dr. Klotz. So will we see a day where this is the case for handheld as well? It's not too far away. And that's it. I think in the same thing too, for those on the call who do any radical prostatectomy, and you're about to cut through the bladder neck. And I've done my fair share of radical prostatectomies, and I always didn't like having to deal with bladder necks with the middle lobe because it requires more reconstruction. It's a tougher anastomosis. So, and the residents are like, I want to do the case. Well, hold on, this may be a tough one. Why? So before we start the case, before prep, I'd launch this on and say, hey, is there a middle lobe? And, this is a case where there was, and you can see a little bit of a protrusion here as we lighten the grayscale, as we come back to the bladder neck and we move to surgery. And, there's that middle lobe. And we knew that ahead of time. So I'd already asked for the V-lock suture, grab the middle lobe, lift up. So I was prepared. It didn't catch me off guard. Really, if there's one big portion that I think that's the big savior here, is time for me and the patient. So prior to 2000, let's say 15, when I got started with this, this is me and the patient. So we're in the room, we need an ultrasound. What does that mean? I'm going to get a piece of paper, stamp it out, put a sticker on. Sir, you get an ultrasound. He'll spend some time getting his appointment, searching around different clinics. Where do I get my ultrasound? Meet with a technician, not a doctor himself. There's no information. They ask questions. What did you find? I can't tell you. They do the ultrasound, they leave, nothing gained. They don't know what happened. Then a radiology technician will show the images to the radiologist. They'll dictate a report that then gets transcribed. I know some centers, they also have AI, Dragon Dictate, and then that gets sent by whatever methods, fax or what have you, to the clinic. And then finally, the patient has to come back and make an appointment. And here you are now, if we're lucky, 4 to 8 weeks later, we go over the results together. And you have to yourself as a physician go, who are you? What's the notes? What was our discussion last? Whereas now, seriously, I spend 2 to 3 more minutes. I'd get this ultrasound. I spend some time and I go right to the diagnosis of what we need to do. So time, cost, anxiety, trust, all those things, I think we just become more efficient. Here's some stuff on the AI. Again, I think AI is the buzzword. It's like the hot topic in every conference now, but really, this is going to be, to me, this is where we're at, developing patterns, helping us become better transcriptionists too, making better decisions with real world data. But simply, you click a button, it'll scan for you, it'll pick up your volume, here's your report. And I dream of a day too for like a auto prostate where you pick up the middle lobe, what's the prostate size, what's the bladder wall thickness, maybe an algorithm to say, compared to the last few years, this person is 3 or 2 years away from being in retention. Let's do something now. So signs of deterioration. So I think that may be our cost-effective model globally to help pick that up. So again, really to standardize and democratize the evaluation, maybe the treatment options, we can create these 1-2 page reports, which I'm already doing, which picks up those details. It saves time and potentially for billing, which we had talked about. That's it. I think, and again, the temporal changes that our patients think we know, and we remember their prostate from this. We know that's not a very good tool, especially after 50 grams. It's a bit of a guesswork. So again, I think POCUS allows us to be more accurate, deliver timelier care. I just think of the whole, at the end of the day, my mom used to tell me, People will forget what you told them. People forget what you did to them, but they'll always remember how you made them feel. So if you can change that experience and make that like that moment something memorable, I mean, isn't that what we went to medicine for, to help touch and help other people? And really, this is a true contact type of care to our patients. So, and again, it's small, it's portable, it connects to pretty much any phone that's out in the market. It's HIPAA secure, it's low cost relative to the cost of what even a bladder scan costs. You know, I think in the future too, I think this whole idea of remote healthcare. So will I dream to see of a day that something, this crystal will be on the tip of my finger, or maybe that of a patient, so that they can go to their grocery store. Hey, let me just check my carotid and see if I've got some plaques, or has my prostate size, or part of a chair that we sit down. I mean, the sky's the limit here. But right now, I think in 2024, to me, at least my practice, this is the standard of care. I just think it takes me beyond God-given five senses. And certainly, as we know, as urologists, this is, you know, medical students sometimes ask, how do you know? Why is it 40 grams? And I'm like, we don't know. It's either a tangerine, an orange, or maybe a grapefruit. And we don't know the y-axis, and we don't know if there's a middle lobe. And so much is more than that. And for that, I just think that, you know, the Clarius system has really helped me in my practice. So thank you for listening. And I guess we'll move it on to Shelley with the next steps.
Yeah, thanks so much, Dr. Zorn, for that informative presentation. We're going to hand it over to Shelley for a live demo. A reminder to everyone to stay with us for the Q&A. We have a bunch of questions that we would like to get to before the top of the hour, but first we're going to hand it over to Shelley.
Great. So I'm just going to start with a little scan of the bladder here. And as you can see, I'm gone up into the correct preset, and I'm going to use the bladder preset in this case. And that just optimizes my images more for bladder imaging. And I'm going to start in the transverse plane here and just kind of show you what we're seeing here. So I'm going to just also going to turn on something called voice control, so that, because I am standing away from my my iPad, sorry, while I'm scanning, but I want to be able to operate some of the controls. So I want a brighter image. I'm just going to say increase gain, and there, it's done it for me. There's a little microphone flashing at the top, and that's how I know that it's working. So in this situation, we're seeing the nice black bladder and the prostate just behind. And what I can do is decrease depth if we want to look at the bladder wall a little bit better. And if I want to just freeze the image, I can go into the measurement tools here. And what we can do is do a bladder wall measurement. And as Dr. Zorn was mentioning, all of this information, if we use this calculation package, is going to go into the report at the end. So it's really handy. Now, the next cool thing that I'll just mention that we could do measurements of the prostate here as well, to get the volume in two planes. But what I'm really excited to tell you about is our new Bladder AI. And so what it's going to do is I'm going to just turn on the AI button here for bladder volume. And the first thing you'll notice is that there's an overlay. I can adjust the opacity here that actually highlights the bladder. So what's really nice is for learners who aren't quite sure where the bladder is, they know they're in the right plane, they know they're scanning right above the pubic bone, but what exactly is the bladder? And this is just going to highlight it for them. And another bonus is that it's telling us that we're in the transverse plane here. If I switch to sagittal, it's going to recognize that as the sagittal plane. So let's start with transverse. And what I can do now is, if I say freeze, the AI is going to place the calipers on the bladder, our first two calipers, and we'll see our height and width here of the bladder. And now if I take a picture of that, unfreeze, and now I go into the sagittal view. Oops, I'm hitting the wrong button here. So again, this is recognizing this as a sagittal view. And when you hit freeze, it's going to place our calipers again and automatically calculate our volume here. So really, really valuable, quick, easy to use. And again, these numbers are going to go into the report page. So it's pretty slick. We can also adjust the opacity of that overlay, while we're frozen as well. So it's going to unfreeze. And I think we have a little bit of time here. I'm just going to turn off the AI for a second. And what I can do is I can go up and just do a quick scan of the kidneys here. So I'm going to go into the abdominal preset, and again, just optimizes it more for abdominal structures. And I'm just going to go on to move your arm up, a little cold here, sorry. Right, I'm just kind of scanning intercostally here. So we've got a nice big rib shadow, liver, and then the upper pole of the kidney here. But a really helpful tool is to have them take a big breath in and hold your breath. And there we're seeing a nice view of the entire kidney. So the cortex is the outer part. We can see the nice bright fat inside the kidney. And if we were going to see hydronephrosis, we'd see black in this area. We can breathe. And then I can also do a transverse view. So big breath again and hold it. And so I've just rotated my scanner 90 degrees, and we're just going from upper pole to lower pole, looking for any fluid. And if you're lucky, there's a bright white stone in there, it'll cast a shadow behind it. You can breathe. Great. And just one more helpful tip, if you're really having trouble seeing the kidney, sometimes on bigger people, it's harder, or just depending on, if things are just tucked really high up under the ribs, get you to turn on the side. I get them just to get them into the decubitus position. And then I can squeak right underneath the ribs, big breath in again. And we can get a really nice look at the kidney there. And again, just sweeping through it. Great. Good.
Making it look easy and straightforward as always.
I always loved scanning kidneys. Now, before we open the floor to live questions with Dr. Zorn, I invite you all to take this next poll just to let us know if we can provide further information about Clarius wireless ultrasound, whether it's the C3 or the EC7 or the L15 linear. Do click on as many as apply. And while you complete the live poll, I'll take a minute to introduce you to the Clarius HD3, the world's only third generation line of portable ultrasound scanners, now 30% smaller, lighter, and more affordable. Clarius delivers the best-in-class wireless ultrasound. Our C3 curvilinear scanner is ideal for transabdominal urology assessments like I showed you, like the kidneys, the bladder, and the prostate. And the Clarius scanners are powered by AI, as you saw. They deliver up to 8 times the processing power and frame rates of other handhelds. You'll get the performance and the image quality of more traditional ultrasound systems, but in a small ultra-portable device for a mere fraction of the cost. Our scanners are IP67 rated, waterproof, and fully submersible for rapid disinfection, and include a complete ecosystem that includes an easy-to-use app for your iOS or Android devices for unlimited users. And for exam management, as Dr. Zorn showed you, we've got the Clarius Cloud that's included with membership in the Advanced Primary and Critical Care package. You also get AI-powered tools, specialized abdominal bladder imaging, including the new Bladder AI for quick bladder volumes. Having your Clarius means there's no need for an additional expensive bladder scanner anymore. Now, I'd like to also tell you about a promotion that we're offering to thank you for attending this webinar. You are all eligible for the Clarius Urology bundle, which consists of 2 scanners, a C3 curvilinear and the EC7 endocavity scanner. This bundle also includes a 3-year membership and 3 years of Clarius Care, which is the extended warranty. Bundling pricing is available for purchases completed on or before May 31st, 2024. So please scan the QR code or go to clarius.com/urology offer to take advantage of this promo. And one more quick poll before we get to your questions. We have a webinar coming at the end of May with guest speaker, Dr. Tatiana Havrelek. And this is your chance to pre-register for this. Now, for anyone interested, the topic will be all about bringing POCUS to your primary care department, and she'll be talking about best practices for documentation, insights into possible ROI associated with POCUS. Dr. Havrelek is really passionate about making POCUS work for everyone, not just in the ED. So please join us for some great information. And now I'd like to welcome back Dr. Zorn and Dr. Frankel to answer your questions. So please use the questions icon in the menu bar to ask questions. Dr. Frankel, I'll ask you to moderate.
Great, yeah. We've got a bunch of questions, and let's see what we can get through in our allotted remaining time. The first question is, how do you, Dr. Zorn, go about sterilizing your endocavitary probe? There's a lot of dispute and challenge on how to do this in a clinic setting versus or bringing it into the hospital. I don't know if you bring yours into the hospital. It's probably just in the clinic. But how it gets used and how you kind of do, what's your workflow between patients?
Yeah, so I mean, my workflow between patient and the clinic is this. This is really so this sterility is usually one of those, the cavity wipes and so forth. I'll rinse that down, and that's good between patients. The endocavity, I usually hand to the nurses. There's a special solvent. There's, I think they worked with Clarice to figure out which ones they are, and we can offline go through the difference depending on what part of the world you're at. There's different guidelines on different products used for the safe use on the, you don't want to damage the coating, what have you, on the product. At the same time, you want to follow regulations or what have you. So to me, in my practice, that's it. The endocavity is more for for the biopsies or for periprostatic blocks for REZUM, or my mists. And then the the C3 is my day-to-day extender as part of my, just looking at my, sitting across from here is my bed, and it's right there at the head with the charging station. So it just kind of sits on the docking. I give it with a cavity wipe as I clean up between patients.
One question is, this is outside of my expertise, so I'm going to need you for sure. Would there be any utility for real-time ultrasound during BPH treatments in office, such as UroLift, REZUM, etc., to ensure appropriate treatment and response?
So yeah, absolutely. I mean, I've seen patients where they come and have had a UroLift and they're not doing well, and indications usually 80 grams or less, and it's a year and a half out, and I'm like, you got a 220 gram prostate. So I don't know who measured or how that was measured. So without a question of a doubt, yes, I think when BPH and part of our guidelines, we should measure. So MRI, CT, or ultrasound, and then guys right in front of you, you just check it out. And, it's not a very hard learning curve. So I really, really don't think it's like, I mean, it's so easy. But once you get your hands and you've tested this, and especially in the bladder, the pelvis, you got this lovely bladder that really helps identify. So versus the kidney is a little trickier, inspiration, the left side, you don't have a liver to look against, a little trickier. But like the testicle or the prostate and the bladder, it's so easy. And with it, you can really pick up the middle lobe and help identify those structures that counsel patients. For real time during, I mean, I'd never done a UroLift where I've had someone hold that and kind of see where the needle goes, because once you fire, it fires through and you get that grappling hook on the capsule. I've never thought of doing that. I guess I knew ahead of time that there's a 47 gram prostate. This is the appropriate patient, that distance. My dream one day will be to look a little more accurately at the transition zone tissue, because BPH tissue is not all the same. You have glandular, fluffy, soft tissue, and you have stromal, almost like nodules of BPH for those on the line who do HOLEP, and they're got these like circular beach balls floating around that they can't engage. Well, that's the stromal component. That would be nice to differentiate between and pick up. And I'm not sure we're there yet in terms of the frequency for this, but at least to pick up and plan ahead of time, yes. And also post, I think that's where I've done some aquablations or green lights, and at the first or second visit, I kind of show them this is the new you. When people have like cosmetic surgery, they do the before and afters, but if you can do the before and after of a BPH surgery, and like today I saw a gentleman with 135 gram prostate retention for a while, and I measured him at 30 something grams. I said, welcome to your 20s again. And it just connects. So I think it's kind of nice just for own representation, and to feel that you did a good job, and I think counsel the patient.
If you had to suggest to urologists who are just getting into this, where to start, would you recommend jumping into the endocavitary and prostate imaging, or curvilinear renal, bladder, transabdominal scanning?
Yeah, I mean, if there's one I kind of alluded to earlier, is the C3. I think that's just in terms of the sterilization, the cleanliness, the versatility. So from the kidneys to the ureter to the bladder to the prostate to the testicle to the penis, you can do it all with it. No, it's true. For the penis, you may have to zoom down because it's up to 40 centimeters. You may not need that much, but if you're just looking for a Peyronie's plaque and you want to see if the gentleman has a stone stuck in his urethra or testicular for torsion, whatever, you can do it all with a C3. So to me, the the go-to first thing when you get in urology, I would say, is get the C3, and you can spend all day just, checking things out and looking, see what's normal, getting your hand, getting familiar with the knobology. And really it's just the thumb and you're tapping versus you look at a keyboard on the dials, the zoom, when you look at and I call that like knobology, learning where all the buttons are. But this is much more simpler interface. You also have the video capture. And then the nice thing, and people talk about it, but if you do ultrasound, you get these printouts and you got to then take it, you got to write it, what's the report, you got to type it up or dictate it. Or here, you just got to tap a button. Once you move past the images, you get an interface where you enter the patient's name. You can use the camera to take a picture of their sticker and it populates. Again, all these little small details that make your life easier, and you can generate a report and definitely send that for billing and for the EMR.
And in my last question, kind of to tag on to that, how can you direct, urology is sort of in a niche specialty field. How do you direct people to learn interpreting the images? There's the generating the images, which you just have to learn by practicing and doing it on your patients. But what about interpreting what they're seeing on the screen and learning how to become more accurate of image interpretation?
Well, just experience, right? I mean, in the worst case, you're not sure. Well, send them to the radiologist and do that as well. I think that's, if you're ever in doubt, and just do what you would have done. But there's that. I think, credentialing is important. I mean, as a company, you guys can offer different services to help. But I just think for me, I just feel really comfortable. I still have on the wall here my the AUA certificate here, hands-on urological course certification. And, that was what I did. I invested in that. And I think it's the best thing I did. It's just one of those things like taking a CPR course or whatever. It just gives you certification credentialing. If there's ever a question, you got that. I'm dreaming of a day, I think, the CUA, the Canadian, maybe the European, I don't know the details. I see someone asked a question from Austria, but it would be nice to have that part of residency. I mean, we go through, I could read a mean IVP, I can read a CT scan, great, and wet reads I'm good at, but the ultrasound, I didn't have the equipment, but now you do. You can have it and it fits in your pocket. And I really don't think, to answer again, it's just practice and time and just technique, right? I think part of it, you have to think of interpreting the images, but also getting the good images. And we didn't really go too much, but at the top, you also have different settings. So in the C3, maybe we should pull it up for you guys, but you just don't, it's not just a one size fits all. You have the option of switching between prostate, abdominal, superficial. So there's different presets when I load up. So I got prostate, superficial, vascular, bladder, abdomen, obstetrics, pelvis, hip, thigh, lung, shoulder, musculoskeletal, spine, nerve, cardiac. So there's different settings that also, again, part of the AI, change the resolution to allow you to see the type of tissue you're going to look at. So I think that inherently also will help your better images. And if you see your images and you know your anatomy, you can make better decisions.
Great. Well, we're at the top of the hour. I want to respect everyone's time. Thanks so much, Dr. Zorn, for answering the questions. If there's others that are outstanding, we will get to them in follow-up. And Shelley, I'm going to hand it back to you to take us home.
Yeah. If we will follow up in the coming week if your question didn't get answered, and just keep in mind you are going to receive a PDF copy of the slides and the webinar recording as well. So keep an eye on your inbox. So I'd like to thank you, Dr. Zorn, for sharing your best practices with us. And of course, a very big thank you to all of you for joining us today. I encourage all of you to complete the closing survey to provide feedback so that we can continue to bring educational webinars like today's. So until the next event, thank you, everyone, and keep scanning.
Great. Thanks, everybody.
Have a great day, everyone.